Dear Arthur, dear chairs, dear colleagues, it's a pleasure for me to be here in Krakow. It's my first time in Krakow, and I'm really impressed about the city. And today I have the option to give an overview about induction therapy in multiple myeloma. The one hot topic in this situation is what we have to use: 3 drugs, 4 drugs, and let's see. These are my disclosures, and this is a story, a little bit history. I'm from Heidelberg, and I was there in 1991, and we started in 1992 high-dose therapy with melphalan 200 microgram, followed by autologous stem cells. And you can hear the update from 2013. What was the message that we learned in around 1,486 patients at this time? There's a black line, and if you look at the black line, you can see after 15 years, 18% of the patients are alive. We have long-term survivors in myeloma, and it's a critical question: what is the patient situation? What is the treatment? If you look at the treatment, then we have the red line, and this was started after the presentation from Bart Balaugi about thalidomide, and we started with a relapse treatment with thalidomide. And if you look at 10 years, there's an improvement in around 10% in overall survival. And the green line is very optimistic. You should keep in mind there are some patients included from trials, and you know trials are very selected the patients. On the other hand, these patients received modern drugs like bortezomib, lenalidomide before high-dose therapy, and then maintenance therapy, mostly in these patients with lenalidomide and some patients with bortezomib. The improvement after 5 years in our hospital is 28% in overall survival, and this is very motivating for us. Then a look about the discussion, long-term survivor. And we look to the United States, and this is a result of the evaluation of 7,291 patients, mostly from United States and also from study groups from Europe, from France, Greece, others, and also Germany. And you look here, here's not a plateau in the patients. You see there is a continuous going down. And then you look at the epidemiologist and ask them, then they say, okay, comparing to the healthy, not myeloma affected population in Europe and United States, you have a cured fraction of around 14%. If it's true, it's a question, it's open, and there are controversial discussion at this time. And I want to remember to Bart Balaugi. Some of you know them. He's a very famous person in myeloma, and he started in 20 years before to say control or cure, and his decision was to make a cure. If we discuss about cure, then we have to keep in mind modern techniques to really evaluate the treatment results. This is a picture from German doctors. They went to Little Rock, and the data from these pictures are from the Little Rock group. And you see the red one, that is not the best one. If you have huge myeloma situation with a high tumor burden, then the prognosis is not so good. And now we are evaluating the role of PET-CT and MRT in multiple myeloma. Before we start to discuss 3 and 4 drugs, keep in mind we have severe patients, severe ill, affected by myeloma disease. And you see here 2 persons. On the left side, the lady is only 65, and this lady is 75. And if you make a decision who of them you want to treat, I would prefer the lady 75. Therefore, you should really select the patients not based on the age, based on the clinical situation, and also frail or not frail. And this was done here by Antonio Polamba from Italy. And this is not transplantation. This is patients not transplant eligible. On the other hand, it's in my mind very important to look at these lines. You see here fit and frail. That's are frail, that are fit patients, that's 6 months, and there's a big difference in stopping the treatment. And you can say it's not so important to stop the treatment, what is the result? And look here at the other hand, if you stop the treatment based on infection, based on diabetes and other things, you have a very high early mortality. And therefore you should really select the patients very carefully what kind of treatment is necessary, what is possible. And therefore I look in my daily practice in this recommendation to reduce the dosages in older patients and not fit patients, because you have, on the other hand, if you use the full dosage, too much side effects could be translated in early deaths, and this is a terrible situation. If you discuss about treatment options in Europe, I'm sure it's not in every country possible to follow the European guidelines. Then it's a very interesting time. You see here, transplant eligible for these patients, VID is an option. On the other hand, 4 drugs, DARA, Tumumab, bortezomib, thalidomide, dexamethasone is the option. And in Germany, we have the option also to use DARA in combination with lenalidomide or with bortezomib-based treatment to make an induction therapy for these patients. And you see here, this is a very huge improvement in PFS for the patients, and this is based on lenalidomide, and this is based on bortezomib and melphalan, and you see there's a very huge difference in PFS, and if you discuss with the government, then it's much more important to see there is an improvement in overall survival, and the follow-up has shown that the improvement, highly significant for daratumumab in frontline, is persistent. Now, before high-dose therapy, the question is, do we need melphalan high-dose therapy followed by stem cells transplantation? You have seen the very nice data without any transplant, and the discussion is not finished. In Germany and in Europe, we're saying melphalan 200 microgram at least 1 time is standard of care for our newly diagnosed fit patients until 70 years. And this is a study performed in Italy, and we see here 3 arms. Carfilzomib, cyclophosphamide, dexamethasone, carfilzomib, lenalidomide, dexamethasone with transplantation and consolidation and maintenance. And then here KRD, carfilzomib, lenalidomide, dexamethasone 12 times without high-dose therapy. And this is a second randomization comparing the standard of care lenalidomide with the experimental arm carfilzomib plus lenalidomide. And then you look at the end, what is the message at the end of the day? 4 cycles KRD, followed by autologous stem cell transplantation, and consolidation is in terms of PFS the winner. Therefore, in this trial, we have the situation that high-dose therapy would be the standard of care for the next years. If we discuss about 4 drugs or 3 drugs, this was a very important trial from the French group and from the Hovan group, and then they compared the standard of care in Italy and in French, VTD, and then they add daratumumab to VTD, and then they have a second randomization, and they have consolidation, and then a second randomization to compare daratumumab versus nothing. And if you look at the induction treatment, you can see there is a significant improvement to add a 4th drug, like here, a CD34 antibody to VTD in this situation, and here the overall survival is also improved. If we look at these data, then it's the question how we can manage the patients and how we can make a decision, because the time for PFS, it's longer and longer, and in our ongoing study, the PFS rate after 4 years is 90%. That means we need 10 years or more to get enough PFS events to make any decision. Therefore, there's an ongoing discussion with the FDA about MAD, minimal residual disease, And you see here 10 to minus 6. That is the highest sensitivity based on the number of cells that we have. And if you have a sensitivity 10 to minus 6 and the MRD will be negative, and much more important, the MRD negativity will sustained, then we can discuss about cure. As an example here from this trial, you can see if the patients are MRD negative, here in both arms, the prognosis is the best one, and this is very important. In this trial, we discuss a high-risk patient based on only one cytogenetic feature, and if you have a very, very high MRD negativity, then you can have a good prognosis. Therefore, in the United States, in the master trial, the colleagues were very kind here to start DARA, KRD. You know, there are 4 drugs. Then from the European view, very interesting, not high-dose therapy as an option. Here is for high-dose therapy for all patients. Then you have consolidation. You have a second consolidation. And if you look here, then MRD negativity 10 to minus 5, it's negative. Then you can stop the treatment. This is very important for our patients. They have a very intensive treatment with 4 drugs. They have high-dose therapy. On the other hand, they have some vacation of treatment if they are MRD negativity. And as expected, if you look here after induction therapy, then you look at the induction cycle 4, and then you look here post-transplant, you see the remission rate will be higher and higher. The response rate will be higher and higher. And then you look here in this picture. This is very complicated. You see different different colors. And the message is if you have high-risk patients or not high-risk patients, and the definition is based on cytogenetics, the response will be similar. There is not a big difference if you have high-risk or not high-risk patients. Very important in this analysis is that you have here the group for 1 high-risk, here 0 high-risk patients, then with 1 cytogenetic defined high-risk situation, and you have here the double group with 2 cytogenetic risk. And here you can see the results. Looks very nice for standard risk or without high risk based on cytogenetics. If you have 1 event, it's not so bad for the patient, and if you have 2, then it's very bad for the patient. Therefore, at this time, for daily practice, if you have patients really based on cytogenetic and a double hit, then please use the maintenance as a continuous until progression, and in other situations, you can discuss the patients how is the side effects, and sometimes it's possible to stop. If we discuss about 3 and 4 drugs, then I want presented some data from our own study group. We were founded in 1996, and you see we have performed trials in around 4,000 patients. Those are the trials that we have performed. And at the ASH 2021 and published in 2022, we presented the data here comparing RVD. This is one of the standards of treatment without any antibody. And in this situation, we add to RVD isatuximab. Isatuximab is another antibody against CD38. Then in our study group, high-dose therapy, melphalan 200 microgram is standard of care. And then we have a second randomization. Standard of care is lenalidomide, and the experimental arm is lenalidomide plus isatuximab. In 2017, we were very optimistic to say, okay, if we have an MRD negativity, that would be enough for the FDA to say that it's a new standard. Today, it's not possible to use this definition, MRD negativity, because the data worldwide not good enough to get a positive votum from the FDA. What is the result? If you look here at the MRD negativity, if you look RVD, 35.6%, and if you add a CD38 antibody, you will have 51%. This is a nice result, and very important for our patients is what is the toxicity? And you could here either RVD and RVD, here with the antibody, here without the antibody. The toxicity is similar. The only one what we have seen in this trial, including more than 600 patients, was that we have a higher rate of neutropenia and a higher rate of lymphopenia, not transferred in a high situation in relation to infection. What we are doing now is to evaluate RVD with isatuximab as a standard of care. We use here two different applications. This is IV and this is subcutaneous, and we will evaluate in this trial how is the situation if we have here then also the maintenance. Okay. Then another possibility to treat patients is based on the high-risk situation. And you see here we have a GMMG concept trial. The responsible person is Professor Katja Weil in Hamburg. And you see we have a standard of care for high-risk patients based on ISS 2 or 3, and also here based on this cytogenetic abnormalities. The patients lower than 70 years, very intensive in treatment, 6 cycles isacardi, high-dose therapy, consolidation and maintenance, and this is a treatment for patients not eligible for high-dose therapy. And you can see the rate of MRD, it's very high for the patients. If we look at the patients receiving the consolidation, we had 66 patients, and the MRD negativity 10 to minus 5 is in 63 patients. What we want to do in the next step here is to compare either in these both arms, IV versus subcutaneous, high-dose therapy, and then is a new development in the drugs based on thalidomide, lenalidomide, pomalidomide, and the new one is iberdomide, and we hope that iberdomide will be well tolerated in the patients, and then we will compare iberdomide with and without isatuximab. You see in our vision from the GMMG, 4 drugs would be the standard of care. The response rate is around 50%, 10 to minus 5 plus, and the toxicity is not significant higher as you use RVD alone. On the other hand, what would be the next step? This is an ongoing phase 2 trial. We have teclistamab in the frontline treatment. We discussed about 5 drugs as a little bit similar to the MSC trials, and the decision now is to use only 4 drugs. We deleted bortezomib because the toxicity for 5 drugs in our hands is too high, and then we will go forward with a maintenance also including teclistamab. What would be the next step for the GMMG? We will have a registry to have a longer follow-up as the trials are in the trials necessary, and then we look at the different clones that we have in the ongoing trials. This is a picture from a patient with refractory multiple myeloma. You see there are different clones in the patients. This is before treatment, this is after treatment. And if you look at the trial clones, then you see there are different situations, and the activity in the clones is different. You know that it's an ongoing discussion. What is the development of new clones could be related to switch from one treatment to another treatment. At the least time, some slides about difficulties that we have in Germany. It's clinical trials very, very important. And in this situation, the number of clinical trials in Germany is going down. It's related to the bureaucracy that we have in Germany, and we're fighting very hard to improve the trials that we have in hematology, oncology, and other diseases, and also the number of patients that could be included. We were very happy here in Germany to have a SOP for all our patients. This is around 186 pages about myeloma and MGUS. And you see now we are fused There are two study groups in Germany, the GMMG and the DSMM. The DSMM is headed by Hermann Einzele, and we work now together, and hopefully we will bring the patients faster in the trials and to have good results. This is our study group. The last meeting was in 2019. We will have in some days, in September the 15th, the next meeting in Heidelberg, and I hope the picture will be similar as this old one. Everyone is knowing Corona was not the best time, and here a slide from my hometown. This is Heidelberg. You see the castle. You see the castle with light, and thank you so much for your attention, and I'm very happy if you have any questions or comments. Thank you.
Thank you very much. We are perfectly on time, so the presentation is open for discussion, and I invite you to ask questions. Professor Jurczyszyn.
I have a practical question because the topic was difference between free drugs and for drugs. And when you have patients, you can imagine 60 years lady with renal insufficiency. She's dialysis dependent, and you start treatment. In such situation, you give four drugs or free drugs?
We give 3 drugs because in these trials I presented RVD plus ELO or RVD plus ESA. We have to exclude patients with a creatinine clearance lower than 40 milliliter, and therefore we have not experience. What we had in such patients for experience is, the German experience is VCD, because VCD is very active. You have not to make a real big adaptive on the creatinine clearance. Therefore, the standard of care in our hospital is VCD as soon as possible for patients with kidney damage. Yes? There's a study, it will be published soon with also the patients from your clinic. Katja has done this. We will use daratumumab in the second cycle if we have not so much toxicity in the first cycle of induction. Every one of us is knowing the first cycle is critical for the patients. If we look at the side effects and the severe side effects, mostly they are in the first cycle of treatment.
Any more questions? If not, my question would be regarding the elderly people, frail people. How would you suggest the treatment standard will evolve toward these people? Because most of what you have said was about younger patients with use of transplantation and so on and so on. So.
For our elder patients, I have some slides inside in the presentation. There are 2 things. First is to induce a very fast tumor reduction, and the other one is to avoid too much side effects. In most of my patients, I use DARA, LENA, DEXA as an induction treatment. It's a good situation for Germany that we can do it. Until the age of 75 could be VRD without DARA a good option. It depends in our country what is the payment for this treatment. We have not the possibility to use DARA RVD because this was very expensive over many years. Now it had changed in Germany because Limit, it's from different companies, and therefore it's very cheap in our hands. Therefore, I would say over the age of 75, in my view, it's DARA RD the best one. Up to the age of 75, VRD is a very good treatment. Over this age, the side effects, especially in infection, in my view, are too high.
Yeah, also because I am, over 70 now. In the US, they actually use transplantation with reduced conditioning, which is 100, up to the age of 80. Whether we should also adopt the standard in Europe or not?
In my view, not. There is not a very good comparison between melphalan 200 and 100. From the German side, last ASH was presented by Christian Stracker, a trial comparing RD without treatment versus RD plus 2 times melphalan 140 milligram per square meter, followed by autologous stem cell transplantation. And the PFS and the overall is absolutely the same. I was so surprised about these results because everyone was expecting the PFS at least will be much more longer if you have 2 times melphalan 240 milligram. And you heard from me, we have 2 different study groups in the years before. And from the GMMG, there was a clear statement. We use up to the age of 75, melphalan 200 microgram. If you have a kidney damage, then you reduce the amount of melphalan. That is, in my view, not a real reduction. This is an adaptation on the kidney function. And therefore, we have done it until 75. And now the situation in Germany is the insurance is paying only until 70, not over the age of 70. Therefore, our cutoff in related to age is 70. My personal view is there's an ongoing discussion also for younger patients. Do we need really melphalan 200 microgram? I have presented the data from the Italy group. There are other groups, they have different data. From the Boston group, Paul Richardson presented on the small meeting the data from the very nice trial comparing transplant and non-transplant published in New England Journal, and the follow-up is showing the overall survival is absolutely the same. Therefore, in my view, over the age of 70, I would not use melphalan. On the other hand, the reduction to 100, it's too much. And the last data was 140 milligram per square meter comparing to standard of care RD. It's not the best one. No difference in terms of PFS and overall survival. And therefore, I don't use high-dose therapy over the age of 70, only in very, very selected, very fit patients.
Okay. I have quite short question. What would be your proposal for treatment for a young myeloma patient, so below 50, with high-risk cytogenetics, who is asking for curative option? Because we witness increasing proportion of myeloma patients who are younger, who are well educated, and they ask for a curative treatment.
I cannot give a good answer at this time. Some years before, we discussed about allogeneic transplantation, and we have performed, or we were part of 2 randomized trials comparing allogeneic transplantation with autologous transplantation, and we expected much more better PFS and hopefully a better overall survival. And in the trial from the EBMT and the other one, we have not seen it. Therefore, my recommendation is outside of trials, no allogeneic transplantation. And we heard from Arthur, there is a hot topic, immune oncology. We are now focusing on include bispecific in induction treatment. Could be very, very successful. The results in MRD negativity in 10 of 10 patients in our trial together with the Würzburg group is 100%. 10 of 10, it's only a low number. On the other hand, the side effects are not so low as expected. And what is ongoing, we have ongoing trials of the international basis to include CAR T-cell treatment in frontline. We have seen the data from first to fourth relapse. And for some patients, in my view, CAR T-cell therapy or including bispecific could be an option to further prolong MRD negativity and hopefully transfer a subgroup of patients in cured. I'm not sure.
But even with CAR-T, we have quite low proportion of patients getting remission. So it's about 25%, as I remember. And you have to take into account the very high cost of this therapy. And coming back to allogeneic transplantation, I think we shouldn't take the age only as a criterion. It's advised to use hematopoietic cell transplantation comorbidity index, which is something different. And then for people below 60, you need over 3 points, and for people below 2 points. And of course, it's a helpful factor, but with this strategy, I think even now we can get quite good results with allogeneic transplantation in relapsing cases and in cases with high-risk cytogenetics. In our institution, we did in the last 12 years 1,062 autologous transplants and 71 allogeneic transplants. And in sibling settings, out of 22, only 4 died. It means about 80% are real alive now. And in unrelated setting, among 44, we lost 13 patients in 12 years. So it is pretty good results, so over 70% alive. And in haplo, unfortunately, the number is very low. Only 5 cases all are alive. So I believe that allogeneic transplantation should be performed in well-trained centers, so where the team has experience concerning whole organization, especially post-transplant care. In haplo setting, this very hot point is a case with CMV IgG negative donor, and this is the point that should be developed. So probably we have to immunize donors before against CMV.
I'm not an allogeneic transplant doctor. I started in allogeneic transplantation. I was very young. And then we saw the results with the reduced conditioning. And we were so optimistic and have done in frontline this approach. And what we have never learned is what is the right person, the right patient to choose allogeneic. We have some patients, you know that you are really involved, severe side effects, and in our hands, in the first 2 years, 10% of the patients will die related to side effects if you perform allogeneic transplantation in our hands. And in Germany, the colleague, Professor Kröger from Hamburg, was telling us many years you can cure myeloma with allogeneic transplantation. Very nice presentation, MRD negativity. We have done a meeting in Germany what should be covered by the insurances and what should be not covered by the insurances. And the decision was only patients in clinical trials will get the money from the insurances for allogeneic transplantation. I was not the big boss in this discussion. And now we have a trial for patients in first to third relapse comparing autologous versus allogeneic transplantation. And in Germany, only in very, very selected cases, if you ask the insurances, we will do it in Germany. I'm absolutely sure the graft versus myeloma, it's true. no discussion. On the other hand, we not really could predict the outcome, and therefore we reduce allogeneic transplantation in Heidelberg from 30 to 2 in the last 10 years. 10 years before, we have 30 allogeneic transplantation per year. Now we have only 2, and these are mostly patients with plasma cell leukemia. There are some data, not randomized, only a very small group, to use allogeneic transplantation in this patient as consolidation. This decision is not based on clinical trials with a lot of patients. It's only their own experience, and we do it based on 25 patients.